Okay, let's get going. You scroll up to your bio. We're going to discuss prenatal for deaf and hard of hearing people. There's some clinical research in the community, and so I'm going to be doing the results of that. So I'm going to sign. If you can't see either me or hear the interpreter, please put that in the chat box. The reason that I'm facilitating this discussion with Dr. Mike McKean is that we want to share different clinical perspectives and the research that's come out of the community, from birthing children to postnatal. Now, I am a deaf mom of 3 children. One of them is hearing, one of them is deaf, and one is hard of hearing. So I have so much experience as a mother for these 3 different demographics. So a little bit about myself. I am a member of the Deaf Advisory Committee for the National Center of Disability and Pregnancy Research, and I am the interim director of the Center for Latina Deaf Students, also known as Nuestra Casa, and the associate ombuds at Gallaudet. I'm a deaf mother of 3 children, and Michael McKee is a family physician and professor of the department, associate professor of the Department of Family and Medical Director of the University of Michigan, Center for Disability Health and Wellness. He has extensive clinical research and expertise in disability health. And as a physician with a hearing loss himself, he's especially interested in advocating for rights of deaf and hard of hearing patients. And so I want to deaf and hard of hearing patients to obtain equitable health care, including accessible communication. And his research focus includes health disparity for individuals with various disabilities and health information. So that's Mike. And
I'm so sorry, Norma. Can I ask you, Norma, can I ask you to restart your introduction?
And she's not looking at the interpreter. Yeah. So she's been so she deals with people with severe hearing losses and provides patient care for people during pregnancy. So welcome everybody, and thank you for joining us. Could you do the next slide, please? Just a brief acknowledgement. So this is for training for the National Center for Pregnancy and Disability Research. And the center focuses on a lot of different issues related to pregnancy and reproductive health in general, and children's rights and birth, and anything to do with supporting, like setting up a network, setting up these webinars and this is set up by the National Disability Center, and this center involves the Management for Community Life, the Department of Health and Human Services, DHHS, and this is, and Mike will go over that a little bit more when he takes over. So he will show his organization's view. And next we will talk about some of the discoveries, some of the findings. So, and then we'll give a couple minutes for questions. Mike, I'm going to turn it over to you.
Thank you, Norma. So I welcome everybody. And what I'm hoping to do, I know we have a diverse group of attendees joining us today. One important thing is to understand that there is no one individual that basically is going to match everybody that we meet in a clinical setting. So what I mean by that is that we may have individuals that identify as a capital D deaf. So keep in mind, these are individuals that prefer to communicate in American Sign Language. They also identify their hearing loss as really a cultural identity rather than a disability. They tend to socialize with other deaf individuals and are obviously value the deaf community. That might differ from other patients that we see, either age-related or congenital hearing loss, but prefer to do spoken language, English, Spanish, and so on. Other individuals might identify as actually being more hearing impaired. That's a term that we generally try to avoid, but keep in mind that some individuals still describe or identify as being hearing impaired. When we talk about small d deaf, again, these are often people with more severe forms of hearing loss, but still often will use amplification and spoken language. They may still have a secondary use of sign language. And then lastly, you will often see a lot of our clinical and publication scientific research in which we use hearing loss as more of a general bucket. So hearing loss and hearing disability tends to be kind of just we lump everybody together. So it's really important that we need to think about how we need to engage these individuals. So we use the appropriate terminology, have person-centered language. So in addition to that, I want to also just highlight that this is a very large population. This is a group that we're going to see often in our clinical setting. Even if we're talking about those individuals who might be in reproductive age, there are some studies that have demonstrated that 5% of women in the reproductive age have already have some form of hearing loss. When we talk about a general population, it ranges anywhere from 14 to 17% of the population has hearing loss. In addition to that, there is roughly about 10% of that group will have more severe forms of hearing loss, often identifying as severe to profound hearing loss. And then of that group, about 10% will identify being deaf American Sign Language users. So the deaf group is roughly about 500,000 to 1 million individuals in terms of the size of the population. So again, when you engage these people, ask them how they identify themselves. Also, we'll talk a little bit more. It's important that we need to screen for hearing loss. All right, let's go ahead to the next slide. So why are we here today? Obviously, I told you that hearing loss is common. We're going to obviously see these individuals. What is unfortunately more troublesome is that this is a population that struggles with enormous disparities. That's both pregnancy as well as birth disparities. So Dr. Monica Mitra and our team, we were able to do a publication back in 2016. It was a Sentinel article that identified deaf and hard of hearing individuals being at higher risk, experiencing low birth weight and preterm birth. This was disturbing, and obviously the general population, we've seen a trend to more adverse pregnancy and birth outcomes, and we want to reverse that. But we also recognize that we need to get a bit more research to identify what these trends are being driven by. And so our project that was funded, obviously you saw the acknowledgement, and we're very grateful for NIH funding this project. And what we found was more disturbing findings in which in this, the left side, deaf, hard of hearing birth disparities, you could see very troubling findings of 43% higher odds of low birth weight, 28% higher odds of prematurity. Low APGAR scores were also significantly reduced both at the 1 minute and 5 minute mark. They were also 12% more likely to have a C-section. These are findings that rival any other disadvantaged population. And so we wanted to highlight that we need to do more to address these gaps. And we'll talk more about some of these strategies. If you look at the pregnancy disparities, we see pre-existing health conditions are more common. Both hypertension and diabetes, both were elevated for deaf and hard of hearing birthers. 59% higher risk also for gestational diabetes, and 32% more likely to have preeclampsia or eclampsia. And they were also 98% more likely to have placental abruption. These are very serious pregnancy and birth outcomes. Okay, next.
Mike, if you'll just pardon me for 30 seconds, I'm going to see, for people who are using their iPad, it is difficult for them to see both people. So for those who are using iPads, can you tell me if you can see both Mike and the interpreter now? And also folks who are using other devices, can you let us know if you can see both Mike and the interpreter? Shoot.
Amy, maybe hold because some now are saying yes. So maybe if we can ask to that said couldn't, if you could look and see if you can see it now. All right, Amy, should we go ahead?
Yes,
Yes,
please go ahead, Mike.
Okay. Go ahead. So I also want to just briefly highlight a bit more on the healthcare utilization area. So perinatal healthcare use, what we have done is looked at various types of data. A lot of these are claims-based data, hospital-based data. And what we have also seen is that antepartum, meaning prior to birth, 49% of deaf, hard of hearing women versus only 26% hearing women had at least one emergency department use. In an ideal setting, we would not want them to go to the ED, but to continue to meet and do their prenatal visit outpatient. So anytime somebody goes to the ED, there's an unmet need, there's some acute issue that has come up. And so that was a negative finding that we had. Labor and delivery, they were 12% more likely to have longer stays. Keep in mind, longer stays often reflect that there are some health issues or there is some dynamic happening that potentially could adversely affect the health of the birther as well as the infant. And so anytime you see extended hospital stays for vaginal birth, that is another concern to explore. And then postpartum, we saw 84% higher risk for hospital admissions. And keep in mind, we looked at a series of 1 to 42 days, 276% higher risk if they were within 43 and 90 days after the birth. And then 310% higher risk when you go 3 months and out. So these are postpartum, meaning after they already have their birth. And so again, more complications that are happening after they've already had their infant. Again, this needs to be examined a bit more. And then there's another classification called severe maternal morbidity. These are of high concern conditions. And there's basically a classification of different health conditions that fall under this. And it allows researchers and clinicians to see if a population group is experiencing more burden on a health standpoint. And unfortunately, what we saw, 54% were more likely to have severe maternal morbidity. So I'm going to go to the next slide. Let's advance once more and let's turn it over to Norma to kind of maybe share a little bit about her patient experiences. Thank you.
Hello again. I'm sorry that that there have been some logistics. I'm glad that we have the interpreter. She's kind of following a script too. Let me share my findings for that perspective of deaf and hard of hearing people. Some people have anxiety, nerves, and it doesn't matter if you're pregnant or not. And also, you don't know what to expect every time because every pregnancy is different. So anyone who's experienced pregnancy, they're like, okay, let me go to my appointment. That you've got anxiety, and then if you're deaf, add on to that. They might sign just a little bit, try to work on the communication with the doctor, like gestures and things. So I want to make sure we need to make sure there's an interpreter available, and that takes more time because there are very few interpreters. So there's different logistic things that you have to deal with that you might not think of as a hearing person. So you kind of have to have that in mind. Deaf person equals needing to get an interpreter, needing to communicate. And sometimes it's hard to focus on the baby because they're asking me about my hearing, and I have to do so much to make sure that I have access that we don't always have time to discuss the infant in the way that we need to. All right, Mike, come back. Hello.
Okay, I'm not able to turn my video on. Can you?
Angela, are you joining?
Yes, let me see if I can start my video. Can you see me and hear me? Can you hear me, see me? Yeah, can we move to the next slide? Can you hear me, see me? Okay, perfect, thank you. Okay, so when we're discussing and looking at the experience of deaf and hard of hearing birthers, we need to be able to identify the barriers and that these patients experience, and then not only identify the barriers, but see how we can overcome those and see what facilitators or what things can help support a more positive experience during the pregnancy and the birthing process. So there was a qualitative study that was published in the British Journal of Obstetrics and Gynecology in 2022, authored by Dr. Pankow and Dr. McKee. And what they did is they explored the pregnancy experiences of 45 deaf and hard of hearing women. And the purpose was to identify and understand these barriers, and then also look at the facilitators of optimal pregnancy-related care. So on the left side of the screen, it highlights the barriers that were identified. And the barriers included inconsistent communication access and difficulty assessing health information, leading to the healthcare communication breakdown. And when there's a breakdown in the communication, we're not able to deliver healthcare effectively. And with this communication breakdown, this will cause the deaf and hard of hearing patients to feel like a loss of autonomy and disempowerment. So deaf and hard of hearing patients, they face challenges in being able to access American Sign Language interpreters for communication with their healthcare providers. Oftentimes patients will not feel like they get their full explanation until after they've had an interpreter, or if they have had more time spent with their healthcare provider. So the supportive factors on the right side of the screen were the facilitators that helped counteract these barriers. And so these patients were interviewed, and for equitable and accessible healthcare is one of those facilitators, where we bring in certified sign language interpreters that help with the communication between the provider and the patient. So using ASL interpreters led to more positive pregnancy and birth experiences. We also facilitating the patient-physician relationship is the use of assistive hearing technologies. And this, we'll go into this in more detail with the upcoming slides. But this can be assistive listening devices. It can be like video relay interpreting. It can be cart or captioning, and we'll go more into that. And then thirdly, self-advocacy was important to achieving more positive experiences. So these patients who advocated for themselves, making sure that their needs were being met, or at least they were voicing their concerns and their needs, they were more likely to have positive birthing experiences. Next slide, please. So we want to move or shift from the patient perspective into a clinician perspective. And so the next slide, we'll be going over like the barriers and challenges that we as clinicians face. Next slide, please. So we're looking at the barriers. It's actually multi-layered. We're looking at barriers at a systemic level, a provider level, and patient barriers. So from a systemic perspective, the barriers that we face as clinicians is lack of assistance or coordination of accommodations or interpreters, such as how do we get in touch with an interpreting agency? How do we provide the resources that deaf patients need? Number two, there's a lack of standardized screening for disability and documentation. On the provider level, the barriers that we've identified is that as physicians, sometimes we're short on time and resources. We have a tendency to rush through our clinic visits. And so that's one big barrier between our interaction with deaf and hard of hearing patients. There's a lack of awareness and training, which is why we're doing this webinar, so that we can increase that awareness. Then there's even kind of an unspoken bias. We call it autism, so it's similar. For those who don't know this terminology, it's the notion that one is superior based on one's ability to hear. So very much like racism, sexism. At the patient level, we see barriers and mistrust. Part of this stems from like historic and cultural barriers in medicine, in the deaf population. There's a lack of accessible health information, and then there's significant gaps in the knowledge and shared information in the deaf and hard of hearing community. So facilities and solutions. On the systemic level, we encourage for ways for us to incorporate a universal design. So how to facilitate like the approach to medical equipment and services. We propose to screen for disability and identify what the patient's needs are and what those accommodations are, and if there's ways to kind of flag the charts in the electronic medical system, and then develop accessible pregnancy health information and resources. At the provider level, I strongly encourage consideration to provide like longer appointment times, maybe at the end of the day, so you're not feeling rushed to see the next patient. Other things that we can do as providers is provide clinical care tips and resources on how to care for deaf and hard of hearing patients. We want to develop and require disability health curricula and training programs, and we're talking at all levels of education, all levels of providers, and to provide appropriate and individualized supports. For the deaf and hard of hearing patients, facilities and solutions would be to provide support to ensure positive experiences in the healthcare system, and to increase the number of accessible health information and resources. And like I said, we'll give you examples of how we're thinking to target the patient population to increase or decrease the knowledge gaps. Next slide, please.
Amy, can you get me on spotlight? All right. Thank you, Dr. Angela Hart. So I want to just kind of pivot a bit and start thinking about what might be good strategies to really provide better perinatal healthcare for our deaf and hard of hearing birthers. So we're going to go through a couple of slides on some ideas. Not all of them have been implemented in a perinatal healthcare setting, but we feel that they might potentially be ideas that we can incorporate in those settings. So let's go to the next slide. Hold, there's no interpreter.
I'm here.
Can we have the interpreter spotlighted? Are we good? Thank you. All right. So want to really just highlight the challenges for accessibility. That is something that we have seen across the board with both deaf and hard of hearing birthers. And so there's several ideas that we have, but I want to just kind of give the scale of the barriers that these individuals experience. So we go to the next slide. So this is a study that was led by Dr. Tyler James and our team, really just looking at the access in mental health and substance use facilities. Keep in mind, we do not have any data that looks at how well we provide interpreters in perinatal healthcare settings. However, I expect that it's going to be pretty similar to what we have seen in the mental health and substance use settings. So if you look at towards the left is a map, basically just showing how well we actually provide interpreters for these settings. Unfortunately, what we have seen is very dismal settings in providing interpreters. Mental health settings, only 41% actually provided interpreters to their deaf patients. Just think about that for a second. So the vast majority of people, deaf individuals accessing mental health services do not receive interpreters. That is a clear violation about the legal laws that I will just briefly cover. When we talk about for substance use disorders, only 59% actually provide interpreters. So we're talking about big chunks of deaf and hard of hearing individuals do not get accommodations, even though they have the legal right to act and also receive. So let's go to the next slide. So when I manage and talk with deaf and hard of hearing patients, a number of things do come up that I hear from other colleagues or just their personal stories, and also what we try to address in our primary care setting. So first of all, medication misunderstandings and reduced adherence. What I mean by that, if you don't have an interpreter and a doctor is telling you to do a certain treatment, you don't know why, you don't know the rationale for the medication, why are you going to follow those recommendations? And what we have seen, and there's already evidence of that deaf and hard of hearing individuals are less likely to adhere to medical treatment. That is going to place these individuals at risk for harm down the road, often more health concerns, maybe more severe forms of it. Misdiagnosis and mistrust are huge issues. Obviously, if you're already struggling or you have to have the additional burden of fighting for an interpreter, feeling disrespected. We've had a number of interviews that came up that highlighted autism. Having providers, staff members, or even other members in society basically share that they question the ability of deaf or hard of hearing birthers' inability to care for their infant. So what's happening is that they feel we should not have a child. And so there's going to be a disconnect. Obviously, if someone is already telling or expressing those concerns, why are you going to be connected to those providers? And then the other thing is access to health information, accessible health information is so poor that it's going to affect our ability to understand these health conditions. So health literacy is something that has been assessed in the past from previous studies that we've conducted. And so this is an ability to access information, use it, understand it. So in order to hopefully do the appropriate steps to manage your health condition. So obviously, a lot of these barriers are clear violations of the legal laws that we've already have passed. We have inconsistent interpreters that I just mentioned before, but this also impacts hard of hearing, spoken English, who are trying to get captioning services too. Then lastly, we're trying to do here at University of Michigan, we have a number of deaf and hard of hearing related training programs so that healthcare providers understand what are the care needs that they have, understand that they're bringing certain biases. They may have already internal biases like autism, how they can manage those and hopefully improve on that. So let's go to the next slide. So I want to just briefly talk about some of the important civil rights laws that affect not only deaf and hard of hearing, but other individuals with disabilities. So the first one that was passed was the Rehab Act, Section 504 in 1973. Keep in mind that this only really applied to those who receive public funding, government funding. That was not until we got the Americans with Disabilities Act in 1990. So we mainly have Title II and Title III. Title II mainly in the hospital settings, and Title III are more outpatient settings. That really opened things up. So in a private healthcare clinic before, often they would just say no, and there was no recourse to get that addressed. The Americans with Disabilities Act, through the Department of Justice, now allows to have some recourse to make sure that that hopefully will be addressed. The Affordable Care Act is one that is often overlooked, but is another powerful civil rights law in which prohibits discrimination on the basis of disability. That also includes deaf and hard of hearing individuals. But there are some really key sections in addition to that. In addition to the section 1557 that I just mentioned. So in section 4203, it requires our healthcare system to ensure that we have inclusion of these individuals having accessible equipment. We also have surveys, health information that is that basically targets and is accessible for these groups. That applies to us. And then the last one is the section 5307, requiring that hospitals and healthcare systems need to train their providers and staff how to work with us. And so last week, Joint Commission often will survey and go to healthcare systems to see if they're following the law. So we need to really push for that. So want to just highlight for anybody in a clinical setting, healthcare inaccessibility and inequity that we've already highlighted in the previous slide is a form of social injustice, and we need to stop that. So let's go to the next slide. So I'm going to talk about some tools and strategies that we are doing, and I hope that many of you will take some of these ideas and incorporate in your healthcare settings. So first one, we worked on and have already implemented a disability field in addition to the language field. So this is a mock patient, Big Bird. So we have a fake patient who in a chart, we have now built a disability field in which you can put your disability type. So in my case, I would put deaf and hard of hearing. And then when you go to the next slide, it will populate a disability field. So let's go to the next slide to show that. So if you look at the next slide, it will now populate, and this can be filled out by patients, their caregiver, if it's like, for example, a child, parents can also add that. It can also be added by clinicians and their staff members. You can also, in addition to disability type, will populate more common accommodations that are often required as a reason for that. So why we're showing this, we need to make sure that the information on how to better care for us, we need to have it embedded in our medical records. What we heard over and over again from clinicians is that, I don't know, I didn't know, and then last minute, I don't have ability to get an interpreter placed or get the accommodation set. We don't want to be reactive. We want to have a good healthcare experience for our deaf and hard of hearing birthers. And so what we want to do is be proactive, have that information well in advance so that when the appointment comes up, everything will be set up. So let's go to the next slide. So advances in technology, we're going to turn it over to Dr. Earhart. Angela?
Okay, so advances in technology are increasing the accessibility for deaf and hard of hearing birthers. And we'll give you some examples in the upcoming slides. So the next slide, please. So one of the biggest barriers for us as deaf and hard of hearing individuals is the facial mask, which obscures any kind of facial expression. And as deaf people, we're very reliant on just facial expressions. So COVID actually brought out some good things. It really highlighted or brought to awareness the clear face mask. And you can see there's different brands. But the whole idea is to be able to lip read or see the facial expressions, which really enhances communication. So if the physician can wear it, and if the patient is a lip reader, it enhances that communication. There's also the clear view drape. And for certain procedures, whether it's as an outpatient or inpatient, that clear drape it decreases the barrier between the surgeon or the physician and allows the patient to see just a better view and direct view of the provider. Next slide, please. So there are a variety of assistive devices that are available. Some are older and some are newer. Some adapt to hearing aids. Some are compatible or Bluetooth with cochlear implant processors. So we can start off with the personal sound amplification. That's more like the headphones and the microphone. Some patients will ask for you to wear like a microphone that is connected like Bluetooth to their hearing devices. For parents, a lot of people don't know or are unaware of the tools that are available for deaf and hard of hearing parents to be able to identify their babies crying. And this personally, I have used both of these products. So the top one is you have the monitor in the baby's room, and then the second one with the gold kind of loop on top, you can put that nearby. What I did personally is I put it like under my pillow. It vibrates. It's also a sound component as well. So if you have a hearing partner, I get the vibration, my husband could hear the sound, and you can adjust the sensitivity to how much you want the monitor to pick up an alert. The second example is actually almost like a wrist watch that you wear. Again, you put the monitor in the baby's room, and then you wear the wrist watch, and that vibrates whenever the baby's crying. So these are different tools that we can provide our parents, deaf and hard of hearing parents, to empower them to be able to hear their baby crying. In the next slide, I'm going to let Mike or Dr. McKee take over and talk about how AI is revamping and just care in general and the technology behind that.
Thank you. So AI captioning, I know it's a controversial topic, but in the future, we expect that this is not only going to improve access for hard of hearing spoken English users, and in some cases, some who are bilingual users. And so change is coming, and I expect that this will actually improve the quality of the services that we receive, both in a healthcare setting. I know there are several studies underway looking at captioning, how that's being applied using these AI captioning. So more to come, but keep in mind, if you are developing a video, a healthcare video, make sure you include captioning regardless whether you manually insert the captioning or use some of the beta captioning and then edit as needed. So let's go to the next slide. So obviously, one thing has come up is whether we should be identifying deaf or hard of hearing birthers as a high-risk population. And there are good cases to be built on whether we should do that. And this actually may help us to think about maybe there are clinical decision-making tools for clinicians to help them guide them, for example, assess their mental health, interpersonal violence, also look and screen for conditions that they're more likely to have. So some of the pre-existing conditions like diabetes and hypertension were higher. So it may be helpful to guide the clinician to screen for those more aggressively than what we typically see in the general population. So let's go to the next slide. So the COVID pandemic has, I know, disrupted care for many of us, but it also has given us a really unique opportunity to disrupt healthcare and perhaps even insert some better access for us. Since prior to COVID, we did not have anybody that I recall experience either remote or in-person captioning services. That changed with COVID, where now we do have remote in-person captionists who are able to put it and type it out onto an iPad device. This actually helps many of our hard of hearing spoken English users. And then likewise, some increase with remote staff interpreters. And then, of course, there's also video remote interpreting, which has some drawbacks and often in a hospital setting would not be appropriate in a birthing setting. So let's go to the next slide. So again, when we think about inaccessible health information, deaf individuals right now have very, very few, especially around perinatal topics, pregnancy. There's very few that are available in American Sign Language, especially coming from our major healthcare news suppliers. They're just not existent. So we go to the next slide. And we also need to understand that even for those who are hard of hearing, captioning is not always reliably inserted. Often, sometimes you have to rely on the AI like captioning. So these individuals not only are struggling accessing information that could be useful to help make appropriate decisions for their pregnancy and their upcoming birth, but when you already think about, they're already coming from major gaps in their knowledge base. Their fund of knowledge is lower. When you think about how we acquire much of our health information, our family history, that just happens naturally when you have a discussion with family, a dinner table. There's a concept called dinner table syndrome, where everybody is there chatting about what you think are really kind of minor, not important topics. But we learn from those information. And when a doctor asks us, we can go back, say, I remember I had that conversation with my parents or my uncle or my aunt. I can relay that information to the doctor. A deaf individual or even those who are hard of hearing are going to miss that out. And that also, again, gets replicated over and over again, whether in a workplace, educational setting, and also even in the media. So let's go to the next slide. So obviously, Brandeis University with Lurie Institute and us here at University of Michigan and several providers, same as with Dr. Earhart, we're trying to address some of these gaps. And this is being done through webinars like what we're doing today. And we're also trying to mitigate some of these gaps through Deaf Health Talks. So this is a free community talks and is completely done in American Sign Language where we address these topics. And we have covered perinatal health topics a few times in our past few years. And this is an example of one of our presenters from a couple years back who was able to share information and just talk about expecting a baby, what to do, how to prepare for it. And this is available online. Let's go to the next slide. So it's important to think about just simply writing things out or putting a bulleted point on keywords is not going to be appropriately addressing much of our accessibility concerns. So you need to make sure if a deaf individual communicates in sign language, you need to have an interpreter or need to have a provider who's fluent in sign language. There's just not going to be a replacement otherwise. So be intentional with how you're going to approach it. So in this, we have one of our Deaf Health Talks. Dr. Earhart and myself, we co-presented on this topic. It was COVID and just looking at some perinatal risk during the pandemic. And so this does require effort where we have captioning as well, we're signing it. And so it's important when you make a lot of these resources, think about how we can improve the access, how we can make it inclusive for everybody, not just deaf signers, but also hard of hearing who may rely on captioning. So let's go to the next slide. So I want to just kind of wrap up and make sure we have time for question and answer. So I'm going to skip some slides because we had some tech issues today. So for those of you who are in the clinical setting or perhaps in a educational workplace setting, how do you get interpreters? I would recommend to check with your hospital or medical system, see if you have staff interpreters. Hopefully that's automated where if a deaf person has an appointment, the interpreter will be present. But if not, explore what resources you have available. And then contracting with interpreters in your nearby area. That sometimes could be video remote interpreting as well as interpreting agencies. And then a good organization I would recommend to check into is the Registry Interpreters of the Deaf or for the Deaf. And you can actually search for interpreters in your nearby area. So that's a good starting place if you're looking to have an interpreter in your clinic, outpatient setting. Your office manager or clinical manager can help to make and facilitate that contact and set up a contract with the individual. And of course, Google search, I know many people use and are successful with that too. Let's go to the next slide. So I want to just talk more about the provider strategies on how to hopefully communicate better or more effectively without deaf, hard of hearing individuals. So we're going to go to the provider and then we'll skip to make sure we have time for questions. So let's go to the next slide. So in our deaf health clinic here at University of Michigan under the Department of Family Medicine, we have tried to be intentional to address many of the communication, building, environmental concerns. And so what we did is we asked deaf individual to highlight what was a barrier. Things came up simply like, I just need a signage to know where the lab is so I don't have to ask somebody. Sometimes it was also having accessible questionnaires. We often give depression, anxiety questionnaires, but they're in English. So what we did is we adapted and translated this into American Sign Language, and we have it on our Deaf Health website. So they can actually, they could go watch a signing model and they could select it by using that questionnaire. The other thing is having a door knocker. So when you are changing, disrobing, it's nice to have somebody knock and you have a visual alert. So you know, okay, the doctor is about to come on. I'm going to go ahead, just put my gown on. And it just gives them, a little more sense of peace and feel more calm at the visit. And then for our hard of hearing individuals, we use pocket talkers and another Ryzen, which is an amplification device, especially for individuals who can't afford hearing aid. And then our front staff uses something called an Ubi Duo. It's basically a two-way typewriter, and it's very small on the left side. So I'm going to go ahead. Let's go advance the slide. So if you're a provider, obviously just be intentional. Ask them how to communicate effectively with these individuals. I even do it. It's very easy to assume and make mistakes. And so it's important, how best can we communicate with you? It may be a sign language. It may be not in American Sign Language. It may be doing exact English. It can also be in a different language. And so be intentional, ask them. Sometimes captioning will be asked, or other ways, such as the clear math, will be requested. So let's go to the next slide. And then just lastly, virtual visits, make sure you have a platform where you can have the interpreter place into it. Some virtual visit only have a two-way, meaning you can only see the patient or yourself, but it's important to have 3 or more way, kind of like Zoom, where you could bring the interpreter in and allow for better communication. So let's go to the next slide. So again, I'm going to wrap up here and then we'll save some time for questions. So patient is generally the expert on what works best with communication. So as a provider and staff, we don't get training. Use the expert, talk to them, screen them, ask them how they can hopefully incorporate better communication tips or strategies. Thank you. Let's go provide contact information. So here's my, whoops. So this is my contact information, and Dr. Earhart's contact information is on the next slide as well. All right, so we'll open it up for questions. I'm sorry, we had some tech issues and ran a little bit later. So thank you. Let's open it up.
First of all, I'd like to thank everyone for making this a great webinar. And there's a lot of very dense information here, and it's based on years of research. So I'm very happy I was able to share some of our findings. So we're going to send out both the PowerPoint and the recording And we will use the email addresses you used while registering. And there, anyone else want to add something to the question and answer field? We've got a little bit of time left. So let me look at that Q&A and see if what everyone has. I see a question that says, I know that deafblind is even more disparate. So I don't know if anyone can answer that. Any Seattle interpreters here? Anyone else?
So obviously most of us have had some experiences, maybe one or two individuals. So so we do have experiences, but the struggle is getting appropriate data to be able to examine where these gaps are. And what I mean by that is that I show some slides on some of the gaps, but the claims data, often we could look at hearing loss and look at how they're connected with multiple risk factors. But when you look at hearing loss, in addition to low vision, keep in mind that we don't know if it's deaf blind. These are just simply low vision or having a severe form of hearing loss. That numbers start to get really small, and we often we don't have enough data to look at it. And so this puts them at a disadvantage. So I don't know personally anybody who specializes in this area. It's a huge area. COVID was very disruptive. Many of the interpreters were taken out, and they could not rely, even a remote interpreter, to understand. So very devastating. So I don't have anything else to add, unfortunately. Yeah. So
Thank you
Julie,
so
I
much.
hope Julie can maybe be the one to really explore and hopefully improve on that.
Great. Thank you so much for adding that. All right, let me look at the next question. This is a wonderful Converse presentation, and there are different assistive technologies. Does anyone have any data to share about anything that you have used as far as assistive technology?
Again, there are some articles that look at the use of assistive technology. Most of them are really around captioning. There are some newer, I think we're going to see more studies coming up in the next couple of years, even like smart glasses with captioning and even interpreters being in the glasses. The assistive technology, there are some that use personal sound amplification products in a hospital setting and one, I think, also in an outpatient setting. And then keep in mind, when we say assistive technology, having a clear map to me is an assistive technology. And there's a study that actually looked at wearing it for everybody, even the hearing people liked it. So why not make it universal? Because you could see them smile, and you could connect with your providers better. They trust in them better. And I've been trying to push and advocate that have a clear map for everybody, not just for the deaf and hard of hearing individuals. So it's an uphill battle, but there are some studies available, and I'm happy to maybe steer you towards some of those articles too.
All right, then. Anything else to add, Angela?
Yes. First of all, I want to thank everybody who's watching and even future viewers, they're either online. Let's partner together. There's huge communication gaps, and we can be the bridge. Will you please help us be the bridge in this communication gap so that we can reduce the disparities, we can reduce the adverse perinatal outcomes, reduce, the complications that we see in deaf and hard of hearing birthing persons. So thank you again for your time, and let's work together. And I'm excited to see what kind of future just educational videos that we'll have. And then we also want to support providers and healthcare systems. So it's a multi-tiered challenge, but I'm convinced that we can, just break down those barriers.
Yes. Thank you for your comments, Angela. We have a few more minutes. We have 3 minutes left. Is there anyone else who wants to? Okay, for this question, for clinical decision-making and evaluation in hearing loss, what would that look like for that demographic of the birthing deaf and hard of hearing people? Anyone? Angela, do you want to take that? Well, let's make sure that everyone understands the explanation, and that visual is the most important.
So I'm going to ask if you can repeat the question. I want to make sure.
Mike, do you want to take it?
Yeah, so I think what the other question was, so if me as a doctor, I'm sitting with a deaf or hard of hearing person, how do I know they understood what I was saying? And
Okay.
so yeah, okay.
Yeah, and I think, Dr. McKee can also speak to this. Part of it is this dialogue. I will ask, like, if they can kind of repeat in their own words or their own explanation of what they understood. I'll often ask, like, for example, I have somebody who has diabetes. I'll ask them to repeat the medication back or the dose and the timing of when they need to take their medication. So it's kind of this kind of back and forth dialogue. It's very, very important to make sure that they grasp those concepts. Like if there's follow-up, if somebody who needs frequent follow-up, I'll ask them, like, when do I need to see you again? Just to make sure that they understand that they need to be seen in like 2 weeks, 3 weeks. So it's, Dr. McKee, do you want to add to that?
I think that was perfect. Maybe.
Yeah, I want to add one other thing that I have found very useful as a provider. Any pictures, drawings, or images, just explaining things, because deaf and hard of hearing people are very visual by nature. This one way, they compensate. So anything, like, for example, if I have an abnormal finding on an ultrasound, I will show them the image and then oftentimes refer them to like a textbook or like a drawing cartoon of what's going on.
Okay, thank you. Thank you for your perspective as a hard of hearing doctor and patient. Well, it's 1:01, so I'm sorry. I know we have some more wonderful questions, but keep them for next time. And why don't you email all of us your questions, and we can actually respond to you by email. Thank you so much. That's a good idea. And we will also send the contact information in the slides. And thank you all for being here. Great. You guys have a great afternoon, and we will take care. Bye-bye.